Good evening, everyone. How is everybody? Thank you for coming to this wonderful conference. My name is Jeremy Davis. I'm an acute care nurse practitioner out of Shreveport, Louisiana, and I get the luxury of starting off this hepatology boot camp. It's good to see everybody's smiling faces. I don't see anybody nodding in the crowd yet. Hopefully that will not be the case. So my job is to talk about workup of abnormal liver chemistry. Again, I'm Jeremy Davis. I practice at gastrointestinal specialist in Shreveport, Louisiana. These are my financial disclosures. So we'll go about this with a case study. This is Mrs. J. She's a 52-year-old Caucasian female with a past medical history of hypertension, dyslipidemia, type 2 diabetes, and obesity. Her medications, she was on atorvastatin. But guess what? It got discontinued by primary care when her liver numbers became elevated. We see that quite often, don't we? She's also on lisinopril, and guess what? She's on semaglutide, which as of August 15th, we know what that just got approved for, right? All right. So on physical exam, she has hepatomegaly, family history. Her dad died from cardiovascular disease. Social history, this is where it gets fun. I maybe drink 1 to 5 drinks a week. Do you use any drugs? Nope. What about tobacco? Nope. You do any physical activity? No. Okay. So these are labs from her primary care provider. And what I want you to pay attention to is, let's look at the alk phos, let's look at the bilirubin, ALT, AST, and also that MCV. The whole point I'm trying to make here with these labs are, you can get really good clues just from basic labs that you get from the primary care provider. For instance, what happens when the alk phos is elevated? In our mind, we think about, is there a cholestatic issue going on? When we see ALT and AST elevated, what is going on in the liver cells? MCV elevation, there's a clue. How much do you really drink? So just a gentle reminder, we know that liver chemistries include ALT, AST, alk phos, bilirubin, and a GGT. These are markers of liver injury. Anytime you have LFT elevation, you have to question, what is causing this to happen? Why is this happening? How long has this been happening? So in hepatology and even gastroenterology, these are the things that you're constantly thinking about whenever you're seeing the patient for the first time. And again, pay attention to clues. Now we know that ALT is a more specific marker of hepatic injury than AST. Normal ALT, reminder, for males is 29 and 19 for females. So again, things aren't always as they seem. If you recall on your lab forms, there's a reference range. But even though it's down the middle, it may not necessarily be all it cracks up to be. And I can't tell you how many times where I've had patients come in and they're like, well, we're just not getting to hang out because everything's been hunky-dory for the past 30 years. Everything's been normal, and now it's like not normal. But so keep in mind the reference ranges. All right, think about albumin, proton INR, bilirubin, and platelet count for your liver function test, and understand that decreased albumin and prolonged proton with INR leads to decreased hepatic function. All right, so let's talk about the patient interview. You're chatting with the patient. Little clue, how many of us have been in a room with a patient? We have 15 minutes to see these individuals, get an idea of what's going on, but we ask one simple question and it totally becomes a clinic buster. So what I want you to pay attention to during the patient interview, how long has this been going on? How long have you known about it? Medicines are important. We'll have a lecture later on today about drug-induced liver injury, but think about your over-the-counter meds, supplements, any recent antibiotics. What about the alcohol? What about travel? Are you having any symptoms with it? These are things to think about and try to quantify if you can. The question you don't ask is the very question that you'll get the most information from, so don't be bashful. All right, so let's talk about patterns. So if you're seeing ALT and AST elevated, think about hepatocellular. If AST's 2 times the normal of ALT, think about alcohol. ALT and AST, you have to think about fatty liver or viral. And then your cholestatic pattern, alk phos elevation plus or minus bilirubin, being greater than ALT and AST, or if you have all the above, like with our patient, this is a mixed pattern. So how are we going to work this up? Check your acute hepatitis panel. Some lab references don't have a Hep B total core antibody included, so if not, please check that because that helps us understand if there's been any prior exposure to hepatitis B with a patient that they're unbeknownst to know. Think about your iron profiles, looking out for hereditary hemochromatosis. Check your autoimmune markers. Check an AMA, looking at PBC. As far as Wilson disease, there's an opportunity that age matters, but in our practice, we check it for everybody because we've actually diagnosed an individual at the age of 76 with Wilson disease. So no, guidelines say, hey, if they're less than 55, check it. But in our practice, we're like, if we miss out on it and they have it, then we have egg on our face. So go by whatever you practice, but make sure you assess that, or if you don't feel the need to, then don't. But keep it in the differential. Look at alpha-1 antitrypsin deficiency. Important to understand, sometimes you have an opportunity to look just at the level, but not the phenotype, or to the phenotype. That's very important because that's going to help you understand, is there something that we need to worry with or not? As far as alk phos elevation, check your GGT. I know there's other labs, the alk phos isoenzymes, but sometimes they can tell you a mixed story, but a GGT is going to be more helpful to help you understand if this is elevated due to a hepatic cause or other etiology. And as far as bilirubin elevation, make sure that you fractionate the bilirubin. Check a direct bilirubin and see if there's an actually cholestatic issue or not, or if there's something benign. And always think about a PEth with alcohol. I call it the lie detector test for alcohol. It's a really neat thing. So let's talk about imaging. Our patient didn't come in with any imaging, surprisingly, but you want to make sure you start with the liver ultrasound. The liver ultrasound is going to look for any steatosis. You're going to be able to look at the spleen, the gallbladder, and all the good stuff without really putting them through any radiation. As far as other studies, think about MRCP. If you have a cholestatic pattern, you want to make sure that you're looking at the bile ducts closely to rule out anything like PSC. Think about other imaging modalities such as your MRI or CT of the liver. Let's say that they came in with an ultrasound and there's a goofy spot on their liver. You need to look at that closer. Fibrosis assessment. Non-invasive testing is becoming the new happy time. So FIB4, this is a score that you can calculate with basic labs from primary care. Some primary care providers are actually doing this, and if they see a score that looks a little bit wonky, they're referring to us for further workup. But other biomarkers, you can do an enhanced liver fibrosis test. This is a lab test that's going to assess your understanding of if there's risk for advanced fibrosis or not. We also have vibration-controlled transient elastography. That's looking at fibrosis, and it's measuring steatosis and giving you also evidence to see how much fibrosis may be present. Think about MR elastography if you have that option, and then the liver multiscan is another MR opportunity as well. And there's always room for a liver biopsy if needed. All right, so reminder, this is Mrs. J. This is a reminder of what she's been on in the past. And so what about it? So we checked her serologies and everything's looking okay. We checked the creatinine kinase because she was on a statin and was stopped. My mind is like, well, why did they stop it? Were you tolerating it? Yes. Well, my liver numbers got up. Okay. So, but she was tolerating it before. We checked the PEth, it was low, so suggests to me there's minimal alcohol use. Synthetic function's good. GGT was elevated, consistent with a hepatic etiology for her alk phos elevation, and we fractionated the bilirubin, and so it's consistent with Gilbert's. All right, so her liver ultrasound, she had steatosis with hepatomegaly, but everything else looked good. Given the fact that she had a cholestatic pattern with that, we checked an MRCP and everything was looking okay. As far as her fibrosis assessment, her FIB4 showed an indeterminate score. So we followed up with enhanced liver fibrosis testing, yielding a score of 9.3, which is at intermediate risk. And then her kilopascal from the vibration-controlled transient elastography showed F2 fibrosis. Now a little sidebar conversation. What if These guys don't agree with each other. What do we do now? You know, we see this all the time. You can have an ELF that's low, you can have a fiber scan that's erroneous, like it's not telling a complete story. So MR elastography is an option if you have an opportunity to do that, but also that's another consideration for where liver biopsy may come into play. All righty, so what are we gonna do with Mrs. J? She has steatotic liver disease, that's her diagnosis, F2 fibrosis. So lifestyle modification, Mediterranean diet, exercise. So if your patient is on semaglutide or a GLP-1, resistance is helpful because a lot of times they can have sarcopenia and muscle loss with GLP-1 use, so that'll combat against that. And also guidance has told us, hey, try to lose 5 to 10% of your total body weight if possible. That's lifestyle modification. As far as alcohol, moderate and stop if you can. And then also consider pharmacologic regimens for MASH. And we know that semaglutide has just gotten approved. We also know that resmetirom, she's a candidate for that. So as far as the statin, she didn't have any issue with it. I would say resume it. Why? Because she definitely has cardiometabolic risk factors. She has hypertension, hyperlipidemia, she's diabetic, now she has MASH. So the opportunity is you want to reduce that cardiovascular risk factor. So statins are actually indicated with patients with liver disease in this situation. All right, I try to keep the time wise with 3 minutes left to spare. Thank you so much for your attention.